What has been some of the biggest misconceptions around obesity to date?
Well, historically, the shame and blame was always placed on the individual who was living with obesity. And I've seen it so many times. It wasn't very well taught at medical school either, to be honest. So I think most medical professionals had a incomplete education on obesity and metabolic health, and hopefully that's changing. In the last 20 years, we have had really good research into obesity and really good medications have been developed.
Welcome to the Motherhood Clinic, a podcast about caring for mothers after childbirth, led by clinical experience and real-life stories. If you're a new mom and ever asked yourself, is what I'm going through normal? Should I be worried? Or who should I ask for help? This podcast is for you. It's for anyone navigating those early weeks, months, or even years after having a baby. Each episode brings together voices from across the motherhood journey, from clinicians, experts, and mothers from all walks of life. We're here to help you feel more empowered in your unique motherhood journey. We believe in a better start to motherhood.
Welcome to the second episode in this mini-series, where we are lucky to have Dr Fareeha and Dr Fiona as two clinicians that have worked together. In the first episode, we talked about gestational diabetes and the risk, the prevalence, but also what you can do about it. In today's discussion, we want to talk about obesity. So if you're suffering from it or you're at risk of it, what are the dangers of it? How can you treat it? Why is it important to treat? And what can be done from a medical perspective and a non-medical perspective? So that's the conversation for today. I'd love to hand over to you guys briefly and talk a bit about the context within which you see this, some of the insights to help set the scene for today's conversation. So can I hand over to you guys to provide the landscape for today?
Yeah, great. Thank you. So obesity is a chronic disease, actually. I want, first of all of the viewers, all of the listeners to kind of understand and maybe unlearn other things they may have been told about obesity. Obesity research and understanding has come a long way in the last 10 to 15 years. And now we understand that obesity is a medical condition. It's a disease. So we want to move away from shaming and blaming the individual, because obesity is so incredibly complex. It's not as simple as calories in versus calories out and, eat less and move more. We've moved away from that paradigm now. So the people that are listening with obesity or overweight or people that they know, we need to help everyone engage in a different conversation. So that's the first thing to say. The second thing is obesity is sadly on the rise, and that's partly because of the modern food environment, our modern lifestyles with more and more sedentary behaviors, sedentary jobs. Poor sleep is something that I'm seeing a lot, particularly here in Dubai. People just don't sleep. Sleep can really impact hunger and your will to exercise, and actually the effectiveness of exercise as well. So obesity is incredibly complex. It's on the rise. And where I'm interested in obesity is particularly helping women who are planning to get pregnant, women who are pregnant, and after delivery and through later life as well. I'm seeing women who are in perimenopause, menopause, postmenopause, who have been living with obesity for decades. So I want to help particularly women at every aspect of their kind of fertility journey and their journey through womanhood.
Exactly as you say, it's just because it's so much more prevalent, like up to about 24-25%. And I guess we have a measure which I don't think is fantastic, but the measure that we use is BMI, so body mass index. And the cutoff we tend to use, and I think again it's quite generic because it's not ethnicity specific as such, is obesity would be classed as having a body mass index of 30 and above. So for me as an obstetrician, what it is about how we can optimize surveillance in pregnancy. optimize outcomes in pregnancy and also what happens in labor and recovering afterwards. So it's just sort of identifying, because sometimes women who have obesity may have other problems, and it's probably quite closely linked to diabetes, either pre-existing diabetes or developing diabetes in pregnancy. So it's just, and sometimes, like with diabetes, having a multidisciplinary team to look after, not necessarily every step of the way, but just making sure there's a really clear plan. Again, the women being at the center of everything, for them to know what their birth plan is going to be and what the contingency plan might be as well.
Great. Can we talk really about definition? You mentioned BMI there. So, on the scale from left to right, where there's someone that's overweight versus obese, what is that line and what is the definition? And then we'll talk about the impact that has, on birth and post-birth.
Yeah, so BMI is a very simple calculation which we can do in clinic. It's weight in kilograms divided by height in meters squared. So you can get lots of free BMI calculators online. As Fiona said, actually BMI is a screening tool. So it's a way to screen somebody to see what category they fit in. So generally speaking, a normal BMI is 19 to 24.9, and 25 to 29.9 is overweight, and 30 and above is obese. If there's further definitions of obesity based on whether somebody has an associated medical condition or not with obesity, because obesity is associated with absolutely an increased risk of type 2 diabetes, but multiple other problems like blood pressure, high cholesterol, heart disease, sleep apnea, lots of different cancers, arthritis. So many different problems can be associated with obesity. So we define obesity, but then we often diagnose other conditions which an individual may not know that they've been suffering with. The one I see most commonly is sleep apnea, and actually sleep apnea in women can often be misdiagnosed or underdiagnosed. So obesity is complex, and it is related to lots of other medical conditions.
I wanted to come back to a couple of points you mentioned, Freya. One around unlearning what people understand so far. What has been some of the biggest misconceptions around obesity to date, and why? And what is the difference now in terms of our understanding? Can you talk a bit more about that?
Well, historically, the shame and blame was always placed on the individual who was living with obesity, and I've seen it so many times. It wasn't very well taught at medical school either, to be honest. So I think most medical professionals had a incomplete education on obesity and metabolic health, and hopefully that's changing. In the last 20 years, we have had really good research into obesity, and really good medications have been developed. So pre-existing like diabetes medications have been adapted and have become better and better. So we've been using the current weight loss injections, that class of drug we've been using in diabetic people for 20 years. But 20 years ago, these injections were not as effective as they are now. So they didn't really get the press that they do now. They were like twice daily injections. When I was a trainee diabetes doctor, the weight loss injection, the class of drug that we're using now, that was a twice daily injection, and it was pretty useless. It just lowered blood sugar a bit. It didn't really help with weight loss. But now you can achieve up to 20 to 22% weight loss with some of these medications. And so that is a real game changer. And I think that has hopefully helped the average patient that comes through the door, and also doctors and nurses and allied health professionals, understand that obesity is not an individual's fault, and there are lots of different effective treatments that we can offer. Previously, even 15 years ago or 10 years ago, the treatment was basically surgery. And I can't actually remember the last time I referred anyone to surgery because the injections are so good.
Wow. And that's a relatively short time frame, isn't it? And I think so. The key things I'm picking up is awareness, education, and efficacy has leaped far ahead within our
Absolutely.
generation. And whereas before these were conditions that people often felt that they lived with or lived with the shame of it, actually there are some really effective solutions that can you don't have to live with this. And as you mentioned before, the reasons why you wouldn't want to live with this is clear in terms of the predisposition to certain illnesses or, as you mentioned, chronic diseases going forward, both before and during pregnancy and then afterwards are very clear. So I guess that's a message of hope, I think, for many of our listeners, I hope, where, things can really be done. Can we explore a bit more when you say, you mentioned the complexity of it. We painted a picture here that there are a lot of things can be done. What makes obesity a complex issue to deal with in the first instance? And where do we go from there? So
The issues around obesity, although our understanding has improved, but the current research suggests that there are so many different possible genetic combinations to obesity. So you have monogenic obesity, which is one gene has gone wrong and that leads to obesity. And there are some chromosomal conditions as well. So things that are very obvious. There's a gene that's gone wrong or a chromosome that's gone wrong, and that's been associated with obesity. We've been aware of those syndromes for a long, long time, but the emerging research has shown that there are multiple genes, some that we have identified, some that have not been identified. Some studies show that certain diet may suit a certain type of genetic makeup and a certain diet may suit another type of genetic makeup. And we're not yet there in terms of personalized precision medicine for obesity, but we do have some of the best drugs that have ever been invented. And these drugs are super powerful, very effective, and can be used safely long term in people living with obesity. And the way that I talk to patients about this in my obesity clinic is, when you do a diet and you stop doing the diet, you regain the weight. So why are the drugs any different? When you take the drugs, the weight loss injections, and you stop taking them, you are likely to gain the weight. So diet and exercise, injections, they all are trying to treat this complex condition that is not going away. So we need to take a long-term view of obesity, and particularly for younger women, women that are planning to become mothers, women who are pregnant, women that are after dealing with life after pregnancy and maybe in later life even. We need to kind of get people round to the idea that they can't just keep yo-yo dieting or using medication on and off. We do need to find a long-term solution to optimize their health in the long term as well.
Mm.
I think it's also important to say that because a lot of these drugs are quite new.
Yeah.
So, especially with the GLP-1s, it's really it works dramatically and it really improves diabetic control as well. So some of the pre-existing diabetes type 2, they may come into pregnancy. If they fall pregnant, they will probably have a really good HbA1c, so a really good blood test of the mark of their glycemic control. And then once they fall pregnant, because there's not much data around it, it's not considered safe to continue in pregnancy. So we actually would advise them to stop it as soon as they find out they're pregnant, and ideally stop it as they're trying to conceive. And then that makes it really tricky. Because yes, if you sustain a diet, active lifestyle and keeping your diet healthy, we actually would recommend those with obesity who fall pregnant to keep their weight stable. So it is a myth that you need to eat for two in pregnancy. So we don't want them to lose weight because you don't want the nutritional demands to be compromised for the baby, but you don't want them to gain weight. So we would probably try to aim for, and there's still a lot of research in this area because baby will weigh something, but you want to keep them as weight neutral as possible. And in pregnancy, so would stop the GLP-1s, stop any medicines that would be considered harmful to baby, and start some medicines maybe because there are some risks. So there is a high risk in obesity of developing high blood pressure.
Mhm.
So what we often would recommend is if they were obese with another risk factor, such as age or something else like that, or in some units they would do a very individualized risk. But currently in the UK we use NICE guidance, so they would then be offered aspirin. So 150 milligrams of aspirin taken at night time from 12 to 36 weeks to reduce their risk of developing high blood pressure or preeclampsia in their pregnancy. So some things around about that. And we usually would recommend high dose folic acid in the first 12 weeks of pregnancy. And then we would also need to assess their risk of developing a blood clot, because pregnancy makes your blood a bit stickier, and being obese would further increase your risk. So some women might need to start some blood thinning injections most of the time after they've had a baby, but because the third trimester is also quite a high risk time, if they had additional risk factors, they might need to start taking daily injections from about 28 weeks up until 6 weeks after they've had a baby. So those are the obstetric considerations. And because when we try to measure how our baby's growing, it's quite difficult to accurately assess by measuring what we call the symphysis fundal height. So measuring the bump from the top of the bump to the pubic symphysis. So we try to do that as objectively as possible, but it's not known to be as accurate when the woman is obese or the woman has fibroids and other things like that. So we would recommend serial growth scans to again assess the trajectory of baby's growth.
Got it. Can we talk a moment around attitudes and perceptions? So one thing that struck me when you spoke, Freya, was the idea that you said actually we talk about exercise and sleep, etc., and medication should be seen no differently. We should continue. This should be a lifelong thing. I imagine there might be some that have there's a barrier there. The idea that I have to take lifelong medication. Um, is this a case of reframing people's understanding and relationship with medication, or can it be time limited? So I just wanted to explore that with you.
Yeah, so the current patients that I have using the GLP-1 medications, I have many women actually who are postpartum, so women that have given birth, have gained a lot of weight for whatever reason, and now are struggling to lose it. Obviously, we try and help those women, and we do take a long-term view. So have they been bigger all their life and now pregnancy has just made things more difficult to
Mm,
manage their weight because of, having young children or not sleeping, not being able to exercise? So has this been a lifelong struggle or has that been a recent struggle? If it's been a recent struggle, then they may not need medication forever. But what we know in terms of obesity is that the body has what we call a metabolic kind of set point. So
mm,
the different genes that make up an individual are unique, and that body, that person has a set point that the brain feels happy that this person is not starving, that I'm not starving, I'm getting enough calories and enough energy, and that is different for each person. So whenever you lose weight, your hunger will come back and when try and get you back to that set point. So that's usually the point you were at before you lost the weight. So that is another argument. So if somebody suffers with a lot of hunger or food noise, we call it food noise because that is the brain telling you to try and get back to the weight you were before you lost the weight. So if somebody suffers with a lot of food noise, those types of people are good candidates to have this medication long term, but we usually don't give high dose medication for the rest of their life. We will do kind of what we call microdosing in loose terms, and really individualize that to the person. So there's lots of different approaches to this. There's multiple different ways that we can adjust the medication to the individual. So it's never a one size fits all, and that's kind of the key take home message. You need to get a doctor or a women's health specialist, an endocrinologist, a gynecologist, whoever it is that you feel comfortable with discussing this and discussing long-term strategies to obesity. People should never take a quick fix because that doesn't work.
yeah, and that's an important point to stress in um, the conversations we've had. Is the importance of the relationship between the person and the doctor providing, caring for her, because again, it's that joint decision, and it's not a I go to someone to fix this problem at a point in time. What's becoming clearer and clearer from this conversation, it's the ongoing relationship you have with your doctor or your clinician, and it's an ongoing relationship you have with your weight, as opposed to let me just fix it for this defined period of 9 months, etc.
I see these women and then see them through the pregnancy and then postnatally just trying to optimize to minimize risk of complications. Say they were on a GLP-1 before, when would you review them again, Fareeha? And when would you think about restarting them? I know it's a very individual tailored thing, but most of the time, roughly, when would you recommend restarting? Or
Usually no sooner than 3 months.
okay.
So not usually straight away. The last woman I had, I'll give you an example. She had a 9-month-old, and baby was like, not a year yet, not sleeping through the night, but she had to go back to work, and she was having a lot of joint pains, a lot of low mood, because she had actually gained weight after delivery rather than losing it. And her hunger was insatiable, and she was just pretty miserable. So that type of woman is an ideal candidate for GLP-1s, because once she can get control of her appetite, her hunger, and her weight, everything in the mood will be kind of uplifted, and it actually helps people, particularly women, regain a bit of control when they feel like they're losing control of a really complex situation. So it is individualized, but I've prescribed it many times for less than a year postpartum, as long as, and my key here is that as long as they come and see me as often as they can. So whether I'm happy to see them every month, this sort of patient, or every other month, but they have to maintain a long-term relationship, because the other thing is, it's the same in the UK, it's the same in Dubai. You can buy these medications over the counter. They are safe for the vast majority of people, but there is a potential for serious side effects, even life-threatening side effects, although we don't see those in younger people, but there is a risk of side effects. So I'm trying to move away from people self-medicating and, taking these medications without guidance, because they're very effective and they're very, very powerful. So you need somebody to guide you through and make a long-term plan rather than a short-term, fix.
Yeah. I imagine that again, when we talk about behavior change, one of the things that is, you can see visibly the positive impact because you just shed the weight. But then what you're not doing, again, in the absence of guidance from someone like yourself, is you think you solve the problem and you stop, and then you kind of go back and you yo-yo between these two. And I think, again, saying it's highlighting the importance of, it's not a one-time fix, and it's that that long-term I think, and maybe talk a bit more about I guess the proper and improper use of these things. And again, when you talk about the guidance, what are the kind of things that you would talk about, and what are some of the complementary things that work together with the medication that you would advise people to focus on?
What I would like to frame this as is a woman that's come to see me who's planning pregnancy, for example. I think that would be really useful for a lot of women listening, because I had a patient like this. That was my last patient I saw yesterday. So, young woman, she was about to get married. She was just in the obese category. She was having irregular periods, so she had a tendency to PCOS, and she's getting married and she wants to plan pregnancy soon, within the next year or so. And so she wants to optimize her weight and maybe get her periods back, like to be able to conceive naturally. So the types of things that I would advise this individual around is, again, they have to come and see me every month. We always start with a dietitian review, and I know Fiona knows this very well. All of our women with any tendency to diabetes, type 1, type 2, gestational diabetes, they all get to see a dietitian. So I refer all women who's starting GLP-1 injections to see our weight loss dietitian, to make sure actually that they are getting enough nutrition, that they're getting enough protein, and that they're getting enough vitamins and minerals, because these these medications reduce your appetite, and there's actually a theoretical risk of malnourishment. And that's what we don't want. We don't want a woman conceiving when she's actually deficient in folic acid or vitamin B or vitamin D or something. So we want to make sure a woman is well nourished. We do some baseline blood tests. So we do hemoglobin, iron, B12, vitamin D, sometimes folate as well, basic things like liver function, kidney function, diabetes blood tests. So we'll do those things. We'll start the medication. We'll do a body composition analysis. I'll get her to track her periods, for example, and then we'll see her every month. And I never increase the dose if a woman is already losing weight. So if she's lost weight, she's feeling okay, she's, implemented some behavior change, things like getting rid of processed food, eating more protein, eating more vegetables, then sometimes there isn't a need to increase the dose of medication as long as she's losing weight. Sleep and vitamin D are the two big powerful things that I've found that really complement these injections, to answer your original question, because I could ramble on about this all day. But the two things, when a woman is most women, but when a woman's weight loss is stalling, then I may not increase the dose of medication if she's on a good dose already. I will tell her to sleep, and I'll maybe give her a bit more vitamin D. And usually by the next month, I've found that the weight loss has restarted again. So it is very personalized, but there are some basic things that we do for each person.
Great. I wanted to just give an opportunity to provide that assurance for people that, again, that might have concerns about using medication when they're pregnant. Again, from your experience, Fareeha and Fiona, when you prescribe these things, if it's needed, just to provide, can you share a bit more about the safety of using this long term, both for the mother and for the baby, and just provide that a level of confidence for people that might be concerned about taking any medication?
So that's a great question. There have been there's no evidence that women that have been taking the GLP-1 injections and then conceive, that there are any worse pregnancy outcomes or abnormalities, heaven forbid, with baby. But the recommendation is that as soon as a woman realizes she's pregnant, she stops the medication. But having said that, there are plenty of women who have conceived and have not realized it and have carried on for the medication for several more weeks than they actually intended to, and their babies have been fine. So long term, there's no evidence currently that there's increased risk to baby, but these studies haven't been done in pregnant women because they can never be done. So I haven't seen it yet. I don't know about Fiona. Hopefully you haven't seen it yet either. But what I will say is that these medications I've seen multiple times now, the way that they undo insulin resistance actually can dramatically improve fertility. So I've had multiple patients in the last year here in Dubai where women have conceived within the first couple of months of taking these medications. So actually, there is a lot of anecdotal evidence that they help with fertility.
Fantastic. Anything you want to add to that?
It's really useful to know what happens afterwards, especially so if we do case scenarios. And also the other thing I wanted to touch base on, so great about the nutritional advice and seeing a dietitian beforehand. What about the role of exercise and particularly resistance training?
Yeah.
That's an adjunct. Do you think that's quite an essential role to play in the whole long-term plan?
It's so crucial. So again, there's multiple aspects to this. I can say this as an Asian woman. They've been found to be the members of society that are least likely to engage in any purposeful exercise. So getting someone round to the idea of exercise often takes a couple of appointments. And I usually start with a very basic, very simple exercise plan, which is, as you mentioned, resistance exercise. So one push exercise. So push-ups, which you can do at home, 12 repetitions, a set of 3 push-ups like they do in the movies. So like they do in the movies, like not like the half kind of push-up that you do at home. A proper push-up like you might see someone like Tom Cruise doing. And then pull up
Not immediately postnatal. Just want to say that. Not immediately
that is true.
postnatal.
So if they're planning for pregnancy, for example, then a pull exercise, which can be resistance bands at home or some kind of slightly heavier weights or even like a kettlebell. So one push exercise, one pull exercise, and then one leg exercise, which can be squats or lunges. And you do push, pull legs, push, pull legs, push, pull legs, and you do 12 reps. That whole sequence should take you no more than 20 minutes maximum. So resistance exercise is key. And if they do it consistently, after a month, you will find yourself feeling stronger, particularly if you're eating enough protein, at least 100 grams of protein a day. And then you can move on to going to the gym. The key is to not injure yourself. That's really key. But you don't want to injure yourself, but you also want to engage the muscle in what we call progressive overload. So you want to build muscle fibers. People that have followed personal trainers and things online, they may have heard of this term of progressive overload. So the other tendency that women have is they tend to use really light weights and do longer, like more reps. But actually what you want to do is less reps and a heavier weight, because that's what builds muscle. Women tend to have less twitch fibers. I think it's less fast twitch fibers than men. Men have different muscle makeup. So you do need a slightly different regime for a woman. But generally, the general principles are the same. So if you've never done exercise before, resistance exercise at home, push, pull legs, like I said, 3 times, and then you can graduate onto moving into the gym and just making sure you're not injuring yourself. You don't necessarily need a personal trainer. You can do it yourself as long as you have good form and you know how to use the machines, for example, in the gym. So resistance exercise is key, absolutely key.
That's great. That's actually just confirm what I do, actually. Not that I'm pregnant or planning for it, but I do push-pull legs. It's a very common framework. And I think what's good about that is it's quite easy to think of push exercises or pull exercises, not specific ones. And I think for anyone that is on the journey to starting exercise, it's a very easy framework or accessible framework to think of different variations of a pull exercise or a push exercise. That's why I personally find good about that. So it's good to hear that confirmed. And I think one thing I would reflect
good for
on
for the perimenopause as well.
Yeah.
Great.
Resistance training is really good for
really
perimenopause.
Important.
Yeah.
Yes.
Do you want to talk about that a bit more, Fiona?
No.
Really? Okay, we'll cut that out.
No, but I think Fareeha probably has more to say.
I'm seeing so many more women, previously, again, this is a whole different conversation, but stigma and, shame around perimenopause and menopause was such a prevalent thing across all cultures. It wasn't even any particular culture, to be honest. Most women never used to talk about symptoms of perimenopause and menopause, and I'm seeing more and more women, and there's actually evidence, interestingly, that GLP-1 medication, so things like Ozempic, Wegovy, Manjaro, along with HRT, can actually really help women. So both things together seem to have much better outcomes than if you were to use one or the other alone. So there's now what we're doing more and more is putting women on HRT and these weight loss injections together and keeping them under really close follow-up.
And the push-pull leg.
Push-pull legs, yeah.
Well, that's what's great to hear is, what's coming across is, as I mentioned, this balance between these really effective drugs and medication, which people should be open to, and the evidence, as you guys have both mentioned, as to the safety of using this. But at the same time, not to then almost absolve responsibility, saying, well, actually, let the medication take care of the work. I don't have to do anything because it's going to do what I need to do so long as I'm seeing Fareeha once a month. What we are also advocating is that there are things you should be doing as well around exercise, healthy eating to complement that. I think both are equally important to do in tackling something as complex as obesity. And that's just very good to hear coming through, I think. So, yeah.
Yeah, I think just to add a bit there, So it's really great that we've got like such new advanced medicine, which is so effective. And just knowing that, I think if we frame it from a postnatal point of view, just knowing when it might be safe to restart, because trying to optimize the weight in between pregnancies can really optimize your future pregnancy. Usually would recommend having an 18-month gap in between pregnancies, because your body needs to heal, and there is evidence that with shorter into pregnancy intervals, you have a higher risk of having a preterm birth or late miscarriage. So that gives you that prime time to work on something to get your body to the best that it can be, because you will be a bit older, and that carries some slightly higher risk there, and before you embark on the next pregnancy. Or also, if you're not thinking of another pregnancy, is just improving your overall like health later on. I think Fareeha mentioned this previously, that a lot less women are having to go for bariatric surgery.
Mm.
But in the UK, we're still seeing quite a lot of women who have had bariatric surgery who then fall pregnant. And I just wanted to touch upon that, because sometimes they may have been obese, but then their BMI goes into a low category, so they're not officially obese. But there are implications in terms of nutritional demands
Mm.
for mum and baby, and a safety margin. So some women may have the surgery somewhere else or so, and not have that follow up, because lots of the nutritional supplements need to be lifelong, and they may fall pregnant way too soon. So you need ideally 12 to 18 months after you've had the surgery before you embark on pregnancy. Um, and it's just important for any listeners to know that if they do fall pregnant, to mention it, because they should see a nutritionist. They should be seen in a multidisciplinary clinic, whereby we will check and do additional blood tests to check for like B12, folate, sometimes like zinc and selenium, some of these things, because they might not absorb it as well. Because that they've had surgery to remove part of the stomach or something else like that.
Great, great. No, it's all really helpful, great advice from you both. Um, so I want to take a step back and just say what we've covered so far, and then see if there's anything, and pause from it, is there anything left that we should cover that I haven't discussed already. So again, we talked about um, the prevalence of it, the definition, why it's important to get under control. We talked about, the medicalization of it and what you can do, and also what you can do outside of that. Is there anything that that we should have talked about that we haven't yet, or otherwise we can talk to again, promote some of the resources that are out there and where people can go to for further information? So anything I've missed off?
I think what is important is kind of going back to one of the points I made is if women can optimize their health and their weight before conceiving, that is ideal. Really, to be honest, I'm sure Fiona will agree. Again, Fiona is the one that has to operate on those people and deliver their babies. So Fiona has a very valid way of looking at this. I have a slightly different way of looking at this, but I think we agree on that optimizing weight wherever possible before conception is ideal. The other thing that I tell women in my preconception clinics is, if you imagine a mother's womb, and if you imagine an embryo inside that womb, that embryo is the most delicate thing known to man. It's the most fragile, most delicate thing. So mother's womb needs to be optimized in terms of everything, in terms of blood sugar, blood pressure, hormonal health, because that embryo is so sensitive to the changes in the environment, particularly in mother's womb. And we know actually there's a lot of evidence that just being overweight or obese leads to recurrent pregnancy loss and complications just by the fact of being overweight or obese, even if you don't have other medical issues. So
Mm,
whereby women may be obese and otherwise healthy, that doesn't necessarily translate into a guaranteed healthy pregnancy.
got it. Thank you. Thank you. Have you anything to add?
Um, So I think it does ideally optimizing things prior to conceiving, so that your pregnancy can be as smooth as possible. But even if you haven't got to that stage and you've fallen pregnant and you are obese or morbidly obese, there will be a care plan to try to support your birth choices. There are additional risks with obesity. And we will try to mitigate that as much as possible. And the other thing we touched upon earlier, and I do see it a bit more prevalent, is this obstructive sleep apnea, which is increased with obesity, and that can be very well managed with CPAP. So I've recently in my clinic seen someone who stopped the CPAP because they didn't think it was safe in pregnancy, but it's actually really good to try to optimize things. So that's something they sleep with at night, continuous positive airway pressure, to try to ensure that they're having a restful sleep. So things like that. So unfortunately, I would agree there are additional risks, and there may be limitations whereby they might be recommending to deliver on a consultant-led unit rather than a midwifery-led birthing unit. And they may have an anaesthetic review just as a safety netting to know, in terms of if they needed anaesthetic during the course of delivery or after they've had baby, what would be the safest options, and the risks of all the other things, and maybe consider having, if they wanted regional anaesthesia with an epidural, citing that early, and having a senior person to put it in, because sometimes it became a bit tricky to cite. So some of those things in terms of the best way to monitor baby's heart rate in labour. So I think there are lots of those things. And then if planning for a cesarean section, we want to optimise just to minimise the risk of the complications such as infection, and as I mentioned before, the increased risk of getting blood clots. So I think my take-home message is that yes, try to optimize things beforehand. But if you do embark on pregnancy and you are already overweight, there will be multidisciplinary input, and nothing will be forced upon them. It's just something to just explore. How can we optimize things, and how can we prevent any of those risks that we know are associated with it? So those are my take home. And I think for me, a really good learning is just about postnatally, having a care plan in terms of when you can try to optimize outcomes, and it is an exciting area now.
Fantastic. Again, another, I think, jam-packed conversation with lots of stuff. I think we'll also, in the episode descriptions, refer to any key resources or where we can find further information. But again, just want to say a huge thank you to you both. It's been very informative. And again, for people listening in, if they want to hear, if they have any further questions or want to find out more, to please obviously share feedback where we can maybe have further conversations into this. But just to say thank you both. It's been really good. Any last points you wanted to make, or otherwise promote what you're doing, and we can wrap things up here?
Oh, well, people should follow me on social media.
Absolutely. Tell us. Well, tell us again if they didn't know the first.
Yeah, at Diabetes Care with Dr. F. Rizvi.
Perfect.
And
Great.
that's on Instagram,
Instagram,
TikTok,
Facebook,
and
YouTube, LinkedIn, TikTok.
On all the cool social channels.
All of them.
Please like,
Yes.
subscribe, hit the bell,
Yeah.
notifications, all that good stuff.
Yeah.
Freya, thank you so much. It's been really
Thank
great to
you.
chat to you. I really appreciate your time. And I know it's quite late in Dubai, so I think I really
Yeah.
appreciate it.
No, thank
Fiona,
you.
yeah, and
Thank
I
you
hope
so
we can do
much.
this again.
Yes, absolutely.
Great. Thank you very much.